Now, in addition, one can try to address the inflammation to some extent with other molecules. So, for instance, we know that aloe has anti-inflammatory properties, and desert harvest has a wonderful aloe vera that can be used. They can be used synergistically because they work very differently anyhow. And I always say, sure, take it. In fact, we created a skin lotion called Gentle Derm that is entirely hypoallergenic, can be tolerated by people that cannot tolerate mascara on. And that lotion has aloe extract, oregano extract, olive leaf extract, chamomile extract, and oregano extract that has a molecule that is much more potent than quercetin. And unless there's an open wound, in which case one should not put anything on an open wound unless you put an antibiotic, many individuals that have either vestibulitis or vulvodynia actually use it in that area with what they say are actually useful outcomes. Let me stop there. I gave you an earful. You can ask and then I'll come back to.
Yeah, that was a lot to digest for sure. A lot of really great information. You got me caught up on the cystoscopy thing where you said that you should do it under anesthesia because you might
doesn't show anything otherwise.
I've had
unless you have a horrible ulcer, in which case it will show up. It doesn't.
Right. And so I had a cystoscopy done in office, no anesthesia or anything. It was incredibly painful and it showed nothing.
Yes.
And so they're like, there's really nothing we can do for you since you've done all the treatment options. So you're saying that it really should be done under anesthesia.
Well, yes, with a proviso. As I said, clinically, within reason, one can say, yes, you have interstitial cystitis because of what we discussed. So if one can say that and then move on to potential treatment approaches, the question is, why pay $2,000 or whatever it might cost to go under anesthesia and do that? And when they do it, unless they see ulcers, there's nothing more that you can do about the petechiae other than what we've discussed and we can continue discussing. The only time, and I stand to be corrected, I'm not a urologist, obviously, that could be useful if you see ulcers. Because if you see ulcers during the cystoscopy under anesthesia, the urologist could actually laser the ulcers or might address them in some other way, because the ulcers are notoriously the worst to deal with the kind of things that you and I have been discussing. So I don't want to give the impression that by taking Elavil or hydroxyzine or Cystoprotect, ulcers will disappear. That will not happen. So from that point of view, if the pain is incredible, if there's especially blood in the urine and you suspect an ulcer, then you should do it under spinal or general anesthesia. And I would imagine a urologist would go that route if he or she feels that way.
Mm-hmm. Yeah, and I saw that written in the updates to the American Urologic Association.
Yeah.
So,
yeah. But I clearly will take issue with what they said to you, that an office cystoscopy doesn't show anything, therefore you don't have a problem. That's just not so.
Right. Yeah, I think there's two different things that can happen there. They can either say, yeah, you have IC, but there's really nothing that we can do, or they can say your bladder looks completely normal and healthy, you don't have IC. And I've heard so many people with IC saying that happened to them.
That's totally wrong. They just don't know what they're doing, unfortunately. So
exactly. And that's one of those red flags where a doctor doesn't know what they're doing and you should get a second opinion.
Right. One of my goals, if I can say that, as I re-enter research in this area, and as you know, there will be a symposium at the Nova Southeastern University Clearwater campus on interstitial cystitis on Saturday, March 11th. And I'll have the pleasure to have Dr. Whitmer, Dr. Evans, and Dr. Moldwin actually join us in lecturing there, is also to brainstorm what can we do research-wise to move the field forward, because it has stalemated over the years. One possibility that we are all very interested in is, can we pick up any biomarkers in the urine that have not been thought about or tested in the past, that at least might give us a handle to say, well, look, these are high, very high probability you got IC, because that would be wonderful. It could be a spot urine or maybe 24-hour collection urine. It would be easy, because I don't think we'll score by testing anything in the blood. That's number one. Number two, there may be real possibilities. For instance, I mentioned substance P earlier. Substance P activates cells by binding to a receptor on the surface called NK1 or neurokinin 1. Well, there is a drug that's been around for 10 years that was developed to block NK1 receptors, and it is used for nausea and vomiting, especially related to cancer. Well, it wouldn't be difficult to do a clinical study and use this available drug, since there's plenty of evidence that substance P is high in the bladder, and see if it actually helps. But someone, a urologist will have to do that. I cannot do that. So one of the thoughts might be, can we potentially write to the Department of Defense that every year has announcements for research for IC, and with one of my 3 colleagues or any other colleague, set up a little clinical study. This is an approved drug. It's not very expensive. Maybe even the company might be interested in supporting. So these are the kind of things that I'd like to come out of this symposium, not necessarily inform patients who are already pretty informed, actually more so than many urologists, but also the urologist. So I sent out, for instance, 300 invitations to urologists in all over Florida. So far, only one has indicated he's willing to come. I don't understand why. One should jump at the possibility of learning about something where you see patients and we don't know what to do. Anyhow, but that's true for many disciplines. So.
Yeah, they definitely should, but will they? We will find out.
Same thing with stress. Since we know stress does a job, obviously, one can say, okay, I'll do Pilates, I'll do this. But we know molecularly what happens. So can we, for instance, reduce the release of CRH that resets the reactivity of the mast cells? So I'm a proponent, for instance, I tell every patient, why don't you at least start with a herb called ashwagandha that is fairly decent. It's not a very strong anti-exciting, but fairly decent. It's been tolerated by many people. Maybe if it takes the edge off a little bit, that will be a benefit before you start going into, benzodiazepines or other drugs that are anti-anxiety.
Mm-hmm.
And coming back to the bladder, Algonaut that develops Cystoprotect will be developing one more supplement, not to replace Cystoprotect, but to be given together with Cystoprotect. It will probably be ready by the summertime, but there will be 4 new ingredients, unlike what is present in Cystoprotect. 2 of the ingredients have a lot of information about healing ulcers in general. It could be on the skin, not necessarily the bladder. And the other 2 ingredients have a lot of information published that they desensitize nerve endings. So the Cystoprotect will be addressing the mast cells in the inflammation and rebuilding the bladder lining. The new supplement will be addressing those parts that can be chronic, like the ulcer, as well as the nerve endings. So hopefully that, in addition to the Cystoprotect, will make a difference. Unfortunately, I don't have a name as of yet for it. So if you can come up with a good name, I'll give you credit.
Okay, I'll think about that. So I wanted to ask if someone's listening to this and they're unsure if they could have an issue with histamine or mast cells, like what can they do?
Okay, so first of all, any individual that might have issues with histamine are likely to either flush a little too easily, and it could be flushing not necessarily when it's very hot. You get upset when you're exposed to something. A lot of people would flush when they're exposed to odors. It can be anything from Clorox to perfume. Anybody who develops a little redness around the mouth or swelling in the tongue if they eat certain foods. If they get a lot of GI problems after they eat certain foods, That's kind of telltale signs again of, and of course, itching. They get itching no matter what, whether exposed or eating. So the first approach would be, can you remove some of those foods? And I usually, either you can remove a lot of them altogether, you can remove one at a time. I know people are desperate many times, so it might be easier to say, I'll just go on a low histamine diet. Now, I've seen people having skin and other tissue issues, even when they're either sensitive or allergic to gluten or to casein, in milk products. So even though those are not necessarily direct triggers of mast cells, they've been associated with that. And of course, they've been associated with leaky gut, and leaky gut could affect other organs as well. One item that I'm very, very, I wouldn't say excited, but it's become very important in my mind, is a molecule found in mammalian products, but mostly in red meat, so pork and beef, not so much in chicken or fish. And it's abbreviated alpha, like the Greek letter alpha, -gal, G-A-L, from galactosidase. But we're finding more and more people sensitive to alpha-gal. And unfortunately, mammalian products are found everywhere. So lipstick, chopstick, skin creams contain mammalian products. Therefore, people might be responding to alpha-gal. So if there's any sensitivities of any kind, I usually ask for a panel of immune IgE to allergens. So that would be, so I'll do alpha-gal, casein, gluten, and then of course, things like dust mites, some grasses, and about 5 or so fungi, because I found exposure to fungi could be very, very bothersome. And you don't have to see the fungi. I mean, you can see black mold in your bathroom, but the fungi release volatile mycotoxins. And the mycotoxins stick to clothes, carpets, draperies everywhere. And they do actually stimulate the mast cells. So if you're exposed to mold or mold-like products, you might see issues with your skin, you might see issues with your gut, your bladder, and there are definitely issues with your brain. I've seen people having all kinds of neuropsychiatric problems. Sometimes they call it mastopsychosis because they get so hyper and angry, they just don't know where it's coming from. So these are definite things to avoid or eliminate or minimize as much as possible.
Mm-hmm.
Then, I'm sorry, go ahead.
No, you're fine. So you could try the low histamine diet. You could investigate other triggers that you just mentioned. You could try Cystoprotec. Is there anything else on the more natural side, or would the next step then be like a antihistamine?
Well, on the natural side, so first of all, with Cystoprotec, as with any other supplement or drug, but we don't have drugs, is first of all, you've got to make sure you tolerate it. Every individual is different, so you never know. So I usually tell people, to use olive oil. If you use olive oil, you're fine. Well, you're going to be fine probably because it's pomace oil. And then I ask them, are you sensitive? You eat chocolate, you get hyper. So you try to kind of, and then I say, try one for just a couple of days, one capsule. These are soft gel capsules. And then if you're fine, then you can go one in the morning or in the evening. If you're fine and you have a lot of symptoms, go 2 and 2. I wouldn't go more than 2 and 2, 4 capsules a day. And then give it at least a month. Usually for such chronic problems, it takes about 4 months. So my sort of goal would be, if someone has a lot of symptoms, to address the allergies, take some antihistamine that you can tolerate, go up to 2 Cystoprotec twice a day, give it 3 months, see where you are. If you've got absolutely no benefit, it's not going to help you. I don't know why, since you're not my patient, but I don't know. If it's helping you, so be it. I had an email and a voicemail from a lady whom I saw 2 years ago, who's been on Cystoprotec, and she basically she called me the Greek god because everything is gone. It was really a very nice message, but she built it up up to 6 a day when she was really feeling horrible, and then slowly backed off. And now she's like sometimes 1, sometimes 2. So what I'm saying is, I don't know for every person, and that goes for Desert Harvest or any other supplement out there. We just don't know how much to give because we're not in contact with the patient. We don't know comorbidities. We don't know what else is going on. So my advice would be slowly increase it to a level you tolerate, definitely not more than 6 a day. And then if you feel well, you start backing off and you find basically your balance.
Mm-hmm.
Now, one thing that has happened over the years by many patients, they'll do very well, and then they'll, crisis all of a sudden, everything came back. And then, if I have time and talk to them, oh, well, yes, I like, Mexican food. Well, she was eating, this particular individual, she was eating like 6 avocados a day, and she loved, hot chili. Well, it's not going to work. It's not going to work even for, a stone made out of stone. So, we can't go overboard. We like things, and maybe we can turn to things we like, but again, within reason. If you go overboard, it's nothing is going to actually, shut everything down. So.
Exactly. And just for the listeners, this is not medical advice. Always run it by your doctor before you take something new.
Absolutely, yes.
Gotta say it.
Well, you've got to. Besides, I don't see patients anymore myself. So I give advice to other colleagues. I might give some advice to patients, but I don't really deal with patients. So yes, your statement is very well put. Now, 2 things that come up all the time, and I need your take on those as well. You see the patients, holding a bottle of water and drinking water all the time. Okay, why do they do that? They advise them to drink water all the time. Why?
Because, well, I mean, are you meaning like, why do I carry a water bottle with me all the time?
Well, people carry water just in case, but a lot of IC patients actually do drink water all the time, and they've been told to drink water.
Yeah.
So, I mean, what I've been told, but your answer might be different, is that you wash out whatever is in the bladder that might be irritating the bladder. Is that why they're drinking all the time, or what?
Well, my take on that is that you're trying to dilute the urine so that it's not too concentrated and more irritating to the bladder.
Okay, that means we know that it's something in the urine that's irritating, and we don't know what that is. Actually.
Right. It's the general consensus is that when your urine is too concentrated, it is more painful or can increase your symptoms.
Okay, that may be the case. I haven't seen any paper ever,
Yeah, right. That's
or supporting that. My worry is that if someone drinks all the time, you're going to be running to the bathroom all the time because you're drinking all the time as well. So what I'm saying is, it's got to be some reasonable middle ground here.
I usually tell people aim for like 64 ounces a day, but don't, chug a bunch of water at one point and then do it again later. And you want to sip small sips throughout the day so that you're not overloading your body all at once.
True. Now, there's another caveat with drinking water. And I happened to actually run into this when I was in Europe, and there were a whole bunch of visitors in Greece, and they all of a sudden started having edema, and no one knew why. So what I'm about to say might actually hold true for other conditions, not just IC. As you know, there are many, many, many different types of waters these days that you can buy. And many of them are very confusing. So you'll see purified water. So you have to keep in mind, water that is purified, unless you add salts to it, there are no salts there. This is distilled water, basically, which is fine. But you've got to make up for the salt. Otherwise, distilled water will be drawing salt out of your cells. And that might be very critical for the bladder because it's like doing hydrodistension. If you're just drinking distilled water, the kidneys can correct a lot of things, which will bring me to the next point I want to make. But if you're drinking distilled water all the time, you're really doing yourself a disservice. So, one should be drinking either natural water or purified water to which salts have been added. And usually, if salts are added, they will actually list the salts that are added. And unfortunately, I'm finding more and more waters that say nothing. So, for instance, I don't want to mention a particular brand because I don't want to sound like I'm pointing the finger, but many waters do not have a little label saying so much sodium, so much potassium, so much calcium. I'm a proponent of drinking water that tells you that those are there. Otherwise, you should be eating a cracker every now and then, or a salted, olive every now and then, or something. Okay? I've seen that being a problem. The second is question that comes up. I don't want to drink anything acidic because it will make things worse, right?
Yep.
That's not necessarily true. If you read any physiology textbook, the kidneys correct the acidity. They don't allow you to just stay with acid urine within reason. If the kidneys are overwhelmed, then obviously they cannot fix the pH or the acidity of the urine. But just drinking necessarily something that's slightly acidic does not necessarily mean that your urine will be acidic, in which case it will irritate your bladder. That's why whenever colleagues do instillations, sometimes instillations of certain things, sometimes are cocktails. So there's a Canadian company that has Cystistat, that's basically chondroitin sulfate, basically put directly into the bladder. Other colleagues will use a combination of bicarbonate, fix the acidity, make it a little more alkaline, as well as corticosteroids, because they're anti-inflammatory, et cetera, et cetera. But then again, this is instillation, which becomes a pain in the neck and expensive. You have to go to a physician to do it. And if you do it, you run more of a risk of potentially getting an infection as well, et cetera.
Yeah, so basically summarize that as acid in does not equal acid out.
Correct.
That is a huge misconception in the IC community.
Correct.
Yeah.
So yes, if you're drinking vinegar, it's going to be a problem. Or if you're drinking, grapefruit juice, which is very acidic all day long, that could be a problem. But drinking a glass of orange juice in the morning is not going to make actually, to the best of my knowledge at least, horrible problems. So.
Yeah, and on the other end, it's like anything that's too alkaline can also have the same effect.
Absolutely, yes. Absolutely.
That's where the alkaline water can become a little bit risky because some people will go overboard and then they'll also cause a flare.
Correct. Now, one thing that is absolutely true for people that have muscle-related problems, as well as blood problems, are certain things that are added to drugs, supplements, cosmetics, etc. So red dye, I avoid it as much as possible. And I don't understand why, let's say, Benadryl is red. It's like so many people respond to that. Polyethylene glycol, or PEG, has been shown to be a problem. And some individuals who responded to the COVID vaccines actually responded to the PEG that is found in the vaccines, not to the actual vaccine. So then there are all kinds of other additives, such as monosodium glutamate, which is found in many times in Chinese food, but it's found also in canned foods. So all of those are likely to bother either the stomach and or the bladder, but those are the things that I avoid for people that have migraine headaches as well. So typically I say to patients with IC, if they talk to me, avoid all the things that are likely to cause headaches as well. They're likely to same type of thing, which brings to another type of clinical study. For migraine headaches, we had thought for years that substance P was involved, but all the studies with NK1 receptor antagonist failed, even though, as I said, there is one available for nausea and vomiting. Since then, it was discovered over the last 5 years that another molecule that is released at the same time with substance P from nerve endings, called CGRP, calcitonin gene-related peptide, is involved in headaches. And now there are 5 different medications for prophylaxis of migraine headaches, both injectable as well as intranasal, blocking CGRP. Well, CGRP is released in the bladder as well. So we can do a clinical study with a CGRP receptor antagonist that's available for IC. So there's certain things that are easy. They're kind of what I call low-hanging fruit that we can use. And if we score, so be it. If not, at least that's out of the way, then we'll move on. So again, this is the kind of things that I want to brainstorm with during the conference, hopefully.
That's fantastic. Since we're getting to the end of the time, I just wanted to ask you about one more topic. And when I was doing some research on you, I saw you were quoted on a paper that was talking about estrogen and interstitial cystitis. So
Correct.
can you kind of talk about that and what that is and why people might flare during ovulation and then feel better during
very, very excellent topic. So we've known over the years that autoimmune problems and allergies are more prevalent in females and they can worsen during parts of the cycle. Most of the time, I would say during mid-cycle ovulation, but it could be early on as well. The same holds true for migraine headaches, very typically activated. So we published some papers many, many years ago where we used human cultured mast cells, as we continue to use. We use substance P as a trigger, and then we measure the output. So let's say that you look at a curve, that as you increase the amount of substance P, the output increases. Then we put the cultured mast cells in the presence of 17-beta estradiol, which is the primary estrogen in females. The curve shifted way upwards. So in the presence of estradiol or estrogen, the mast cells were firing more. And then we did the same thing in the presence of progesterone, and that was not true. If anything, the curve shifted down. So it seemed like the progesterone might be a little protective. So since then, we measured actually hormone levels, and in fact, they tracked with the increase of symptoms. So one possibility also, and it's not for me to tell someone what to do, obviously, is whether they have headaches or otherwise, if they are premenopausal, I don't mean just perimenopausal, premenopausal, then it might be worth even considering a progesterone birth control pill, assuming that for religious or other reasons, they're not prohibited from using it, because it's likely to help. In certain cases, we even recommended Lupron, which acts in the brain to shut down. That puts you into a postmenopausal state, basically, to shut down the involvement of estrogens. And they're not everybody, but clearly a number of people do get worse. And what I've typically found over the years is if ladies get pregnant, symptoms subside, and then they come back sometimes with a vengeance after they deliver. But it might be either they forgot for 9 months that they did have a problem and now they have it, all of a sudden, are cognizant of it, or it might be a rebound. It might get even worse. But there's definite involvement of estrogens, no question about it.
Mm-hmm. Yeah, I've been noticing a pretty significant amount of people, whether they're my clients or they're not my clients, telling me that they are flaring every single month like clockwork when they are ovulating, and then they feel better when they have their period. And I think they are getting frustrated, the people experiencing this, because doctors aren't really sure what to do with them and how to help them.
Right. So, as I said, it might be worth considering a birth control pill, taking everything else into consideration, of course. Or if it is so clockwise and horrible, and they're close to maybe menopause, maybe even just getting into early menopause by getting, someone to give them Lupron. Besides, if there's an individual that also has endometriosis, then endometriosis clearly gets worse during mid-cycle. There would be even added value to potentially consider a hormonal therapy for something like that.
Okay. And then what about the women who are menopausal and postmenopausal? Like, is there anything that they can do if they think they have a hormone related response?
Well, the first thing that I would do, of course, is just measure the hormones, because after menopause, technically one shouldn't have. That's why you get, estrogen replacement therapy. Well, for those individuals, I would think twice about estrogen replacement therapy because of this potential. Again, it's someone's life, so I'm not here to dictate what they do. Or maybe instead of getting systemic replacement, maybe it can be local replacement, like, vaginal replacement, if that's the concern or whatever the concern might be. But we do have to address that as a potential, because we know that happens.
Mhm.
Now, one thing that I wanted to mention, going back to stress, because stress is very important in my mind. We spoke about, ashwagandha, but if someone does not have asthma and does not have very low blood pressure, I have found a very old antihypertensive drug, propranolol, one of the trade names is Inderal, is very useful. We can use it actually, it's been used in students before exams, in people who go on stage. We use it in hyperthyroidism because the pulse goes up, and usually 20 milligrams, per day, if your blood pressure is, normal, you don't have asthma because it's contraindicating asthma, might be useful. So you've got to address, of course, as I said, you can use benzodiazepines, but things like Valium, etc., are very sedating. They can cloud your mental abilities as well. Propranolol does not do that. So I usually would go, we recommend ashwagandha and then move on to propranolol if stress is a major factor.
Okay. And if someone asks their doctor, or brings this topic up with their doctor, what specific tests can be done, and like what type of doctor can do them?
For which? Tests for which?
Just hormone like imbalances.
Okay. So any physician can ask for pituitary hormones. Okay. So that would be, estrogen, progesterone, a little bit of testosterone, or the breakdown of testosterone, and then LH and FSH. So, and usually when they give you the results, they will tell you the normal for menstruating or not, or premenopausal or postmenopausal. So you can read the results, depending what category you belong to, basically. But if, let's say, for instance, you're menopausal, and then all of a sudden the values indicate something else, then someone has to look at it, because it shouldn't be that way. And it could be for all kinds of reasons. I don't want to scare people by talking, out of the blue, but that's the first thing I would do.
Okay.
And there's another reason why, and that's because of, as I said, comorbidities. For instance, we published a paper where colleagues of mine biopsied endometriosis lesions, and they biopsied bladder lesions in individuals that had both. And we look for mast cell activation, we look for substance P, we look for CRH. The findings are identical in the paper we published. So in people that have both, it seems like it's the same underlying processes that contribute to both. And then if you address both, you can get, two birds with one stone, so to speak. So that would be useful. Having fibroids is important, because fibroids notoriously are loaded with mast cells. So if you have fibroids, maybe the fibroids contribute to whatever is happening in the pelvic area in general, even though we usually worry about the size and know what they might be releasing. Okay? The endometrium has numerous mast cells. We don't know what they do, the endometrium. The genital organs, I wrote actually a review about mast cells in the genitourinary system, and tried to talk about everything that I could find at the time about what the mast cells might be doing in those organs, for instance. And, at the end of the day, everything that if nerve endings get activated, they move up and down. We have antidromic stimulation. So if something happens in the bladder, it will stimulate the brain, and the brain will shoot back. Same thing in the gut. The vagus nerve goes everywhere. It's the longest nerve in the body. It goes in our lungs, heart, gut, very close to the bladder, not really in the bladder. But anything that is happening in that area is likely to affect everything else. So it's very important to know what else is going on. And by the way, even though we've been talking primarily bladder, similar things happen in the prostate. As you know, we consider chronic abacterial prostatitis almost similar to interstitial cystitis in men, because IC seems to be more prevalent in women than men, but people get that. And we've had a number of people using Cystoprotect with prostatitis doing very well. And in fact, I've got a whole bunch of physicians' friends whose prostatic-specific antigen, PSA, has gone down by taking cystoprotect.
Wow, that's amazing.
Yeah, and there's an added value. As I said earlier, chondroitin and hyaluronate are found in the bladder lining, but they're found actually in the joints. I've had lots of people that had IC and arthritis, and their arthritis is getting better for exactly that reason. It's the same molecules found in the joint. So if we've never heard of anybody having any adverse effect, except if you push to 6 capsules a day, you might get a little irritation in the stomach. And usually if you take like a Pepsid or something, a little antioxidant, that takes care of it. So.
Okay. Well, I feel like this is a good place for us to stop because we could talk forever, I'm sure.
Yes.
So yeah, I'm going to definitely link the symposium in the show notes, and then
I'll send you a new poster only because that indicates it's almost identical. It indicates the times, and they corrected the link. In the poster I send you, you have to copy the link and put it into your browser to actually go to register. The way we did it now, you can click on the poster and that will take you there. I didn't know how to do that, and now they fixed it. So
perfect.
So as soon as we hang up, I'll send you that. And whenever you have the link ready and available, let me know because I put the link on my website as well, so people can visit you.
Yeah, absolutely, can do. But thank you so much for everything you're doing for the IC community, and thank you for coming on and talking with me.
My pleasure. My pleasure. Stay well.